So recording has now started. Hello everyone, I'm Simon Howe from the Health and Wellbeing team at Public Health England, East of England. And today we have Dr. Matt Carney from NHS England and Public Health England, Kate Arnold and Adrian Tomlinson from Solihull CCG, and Dr. Neil Macy from Stowe Health in Suffolk, with the presentations today covering CVD prevention in practice and for people to share their experiences. The webinar session will take the format of a series of presentations by our speakers, followed by a question and answer session at the end, where everyone will get an opportunity to ask questions should they wish. So I'll hand over to Matt Carney now for our first presentation. So over to you, please, Matt.
Rather than the Irish pronunciation. So good afternoon, everybody. So I'm a GP in Shropshire, and I also work for both NHS England and Public Health England in this role as National Clinical Director for Cardiovascular Disease Prevention, which is a nice long title. And I want to talk about CVD prevention in general and where I'm focusing my work and where the national programme is evolving around prevention of cardiovascular disease. And we can move to the next slide. So I'm sure everyone will be familiar with this statement in the 5-year forward view. It was exciting, but it was like many statements we've had in the past, going back to ONLAS and before, that acknowledging that prevention is absolutely key to our sustainability. But there was really a serious commitment to this in the 5-year forward view, and accepting that actually we do need a radical upgrade in prevention. And the initial focus of the NHS following this was on the diabetes prevention programme, largely because this is something that is done in and around the NHS, and there's very good evidence for its impact, and it was something that NHS England felt that they could do at scale, and that is certainly happening. But that's taken up the first couple of years. And over the last year or so, we've been having a lot of discussions to consider, so what next? After the focus on diabetes prevention, what's next? And next slide, please. This culminated in a discussion at the NHS Prevention Board last January. This is a board chaired by Duncan Selby, but it includes NHS and local authority and the third sector and other partners. And an endorsement here in this board that CVD prevention is very much a priority for the health and social care systems. And next slide, please. And the rationale for this will be obvious to everyone, but I think it doesn't do any harm to restate it, just how big a problem and a growing problem is cardiovascular disease for the health and social care system. So it's responsible for around 1 in 4 deaths, 1 in 4 preventable, premature deaths rather. It's very expensive. The figure in the top right has actually been upgraded now. It's over £8 billion a year we spend on cardiovascular disease, 7 million people affected by it. And the twice as high in the top left refers to the health inequalities dimension, and there's probably at least twice, there's probably a difference between the most affluent and the poorest chances of dying of cardiovascular disease is at least twofold. And we know that CVD, heart attacks and strokes, etc., contribute about 27% of to the gap in life expectancy between rich and poor. And I think it's worth restating this and restating it again and again, because if we look at the next slide, this slide has informed a lot of the narrative around cardiovascular disease over the last few years, the acknowledgement that it's a really good story, that there's been a dramatic decline in premature mortality from cardiovascular disease over the last 30 to 40 years. And that's led some people, I think, in healthcare and some people in politics and policy to conclude that it's a done deal. We've sorted CVD, we need to move on to something else. But if we look at the next slide, this is a parallel picture And this shows prescribing for cardiovascular disease in general practice over a similar period of time. And as you can see, an equally dramatic rise in prescribing for CVD, and that partly reflects survival, that more people are surviving after their first event, heart attack or stroke, but also that primary care has been leading the way on particularly secondary prevention of CVD. And if we could have the next slide, please. So clearly, cardiovascular disease still imposes a significant burden on the health and social care system, and it's only going to get worse, as with other long-term conditions. But as our population ages, more and more people will have cardiovascular disease as other long-term conditions, and that will include cardiovascular disease. And the next slide, please. And of course, the population is getting bigger as well as older, and we know the size of the obesity epidemic, and that's absolutely driving the rise in preventable illness and the challenge to the sustainability of the health service. And the next slide, please. But, and I think it's a really important but, and it's always important to acknowledge this in front of any audience, and certainly if we're talking to a healthcare audience, they will always think of this. And if you could just click to the next bit of this slide, and the next picture. And all of these pictures just summarize what we know, that that preventable illness is driven by much more than performance in the NHS, and there are much bigger determinants out there of people's lifestyles and behaviours. And one more click, please. And it's a very legitimate question. So what is it that the NHS can do? And again, another click, please. I think it's absolutely key to acknowledge that's an important question, and to acknowledge in all our conversations that population level measures do have the greatest impact, and that we need to keep on and banging the drum about the importance of tobacco control and support for the wider determinants of people's behaviour, etc. But, you know, I think too often in the past there's been a temptation in the NHS to use this as a bit of a fig leaf, to say that prevention is your business. You know, you need to get on with this. There are bigger issues here, and politicians and local authorities need to be getting and sorting out these wider determinants. And of course that's all true, but I think it has perhaps hidden the core responsibility that we also have in the NHS, and the crucial impact that we can make in preventing cardiovascular disease. So the next slide, please. But just thinking about the wider picture and population level measures, so there is a lot going on nationally and regionally and locally, of course, to prevent cardiovascular disease. And this was an action plan published by Public Health England just a few weeks ago. And the next slide, please. And this has an action plan, and it summarises some of the stuff that's been going on and some of the stuff that we're planning to take forward over the coming months and years. And so we have the plan for action around obesity, the work on a smoke-free NHS, the sequence for a healthy workforce, which are spreading across the country, and really important, focusing some of our efforts on the NHS workforce, which is, of course, is one of the biggest workforces in Europe, and the action on sugary drinks in the NHS. And one more click, please. Public Health England has also been and is continuing to undertake big evidence reviews, so one around international evidence on alcohol control policies, and one that is underway looking at what are people doing around the world on actions to prevent cardiovascular disease. What can we learn from other countries? There's a great deal of work going on to generate intelligence to support this programme of work. So you'll be aware, I'm sure, of the major resources published by the National Cardiovascular Intelligence Network, NCVIN. So there's a range of profiles on cardiovascular disease for CCGs and local authorities, the prevalence models, the primary care intelligence packs, which are a big resource that show for CCGs at practice level what our performance is like around CVD prevention, where is the opportunity for improvement. Public Health England has just commissioned a return on investment tool, which is currently going through a feasibility study phase to identify can we develop a return on investment tool that will be useful to local health economies to work out. So if we take action on, say, blood pressure, atrial fibrillation, what's the impact, what's the cost, how long is it going to take? And we've recently had an agreement with Secretary of State direction to take a major data extraction from primary care, all the data that's relevant to the NHS health check. So that will be a very rich source of information for the health check, but for cardiovascular disease more generally. And one more click, please. So we have the NHS Health Check programme, so big programmes, the NHS Health Check programme reaching 1.5 million people every year now. Uptake's about 50%, but that's still the largest programme of its type in the world. The Diabetes Prevention programme has now reached almost all of the country, will have done very soon, and is on target to deliver 100,000 interventions a year by 2020. Uptake is higher than was modelled. It's around about 50%. I think males are attending slightly less often, but there's no apparent inequalities gradient looking at minority ethnic communities. So that's all very encouraging. It remains to be seen, though, what the persistence is on the programme, what the dropout rate is, how many people go through, and what's the impact on their health. And so that's data that will emerge over time, but a very encouraging start. Click one more, please. And Public Health England has become very focused in its health marketing, using the behavioural insights, learning to get health marketing to be much more focused at populations that we want to reach, and with messaging that's going to have a resonance. And there's increasing use of development of digital support, the Food Smart, Active 10 apps, which are really excellent and I find very popular with people, and the Heart Age tool. So one more click, sorry, next slide please. So just a reminder of the health check. You won't be able to see the detail here, but it's just to remind us all that there are a couple of key elements to this. So this is, first of all, it's about identifying lifestyle risk factors and supporting behaviour change. And one more click. But it's also about detecting high-risk conditions for cardiovascular disease that are undiagnosed, such as blood pressure and atrial fibrillation. And the next slide. And the Heart Age tool, if you've not looked at it, I strongly recommend it. I think it's a really good tool. I find just in one-to-one consultations with patients that it's an excellent communication device around cardiovascular disease, because it's something that people have control on. They put their own information in. They can look at the impact of their own lifestyle change or improvement in blood pressure or cholesterol on their heart age. It's proved very popular. Again, it's about 1.5 million people so far have not just access but completed the tool. So it's getting traction out there. So on the next slide, please. So important to acknowledge and talk about the population and behaviour change support, but I want to focus for the rest of the presentation on what we do in the NHS. So detection and management of the high-risk conditions for cardiovascular disease. On the next slide, please. So you'll all be familiar that these are 6 key conditions: blood pressure, atrial fibrillation, high cholesterol, diabetes, non-diabetic hyperglycemia, and chronic kidney disease. What marks them out is that they all substantially increase our risk of stroke, heart attack, and other cardiovascular events. And I think it's one more click, please. And this is very much core primary care. This is not prevention, that's somebody else's business. This is our day job as GPs and nurses. But what we also know, despite having a very good primary care system in England, late diagnosis and suboptimal treatment of these conditions is very common. And next slide, please. And so I just want to very briefly look at the evidence around these high-risk conditions and our current performance. So if you could click through, please. So we know high blood pressure contributes to half of all strokes and heart attacks. the evidence is overwhelming of benefit. Every 10 millimeters mercury reduction in systolic blood pressure, probably down to about 130 level, reduces the risk of a cardiovascular event by 20%. Another click, please. With atrial fibrillation, we know it increases your risk of having a stroke by a factor of 5, and it's much more likely to kill or disable you. But despite that, we know that, we also, in terms of the evidence for that, anticoagulation substantially reduces that risk by about 2/3. One more click. High cholesterol, again, progressive increase in heart attacks and strokes. And the excellent Rory Collins review from last year in The Lancet, every 1 millimole per litre reduction in LDL cholesterol reduces the risk of heart attack or stroke by 1/4 every year after the first year. So really substantial gain. And one more click. Type 2 diabetes doubles the risk of heart attacks and strokes, and we know that control of these key risk factors substantially reduces that risk. Could move to the next slide, please. And one more click. So this is to look at how we're currently performing. So we know with high blood pressure, we're picking up about 60% of hypertensives, and we're controlling about 60% to the 140/90 target. Next click. With atrial fibrillation, if you take that population of people with AF who are on my register as a GP, of those who go on and have a stroke, only half of them will have been anticoagulated, which to my mind is a striking system failure for something that is such an effective treatment to prevent a disastrous, catastrophic event in an individual's life. Next click. With high cholesterol, national figures suggest that probably about 50% of people, even with a 10-year risk score of 20%, are getting onto statins. And the next click. And with type 2 diabetes, again, it's about half of all people are getting the 8 care processes or achieving the 3 treatment targets. And the next slide, please. And could I have the next slide, please? Thank you. So this is a paper from it was actually the end of 2016. A large study looking at using the SIN database to examine the records of 29,000 people who'd had their first ever stroke or TIA. 17,500 of those from their clinical records had one or more preventive medication indicated, but of those you can see the rule of halves applying. So around half of all people did not get a statin despite its indication, half did not get the anticoagulant, and we did better with antihypertensives, where it was only about a quarter did not get the preventive indication. So the rule of halves that I was taught in medical school 30 odd years ago is still alive and kicking for our patients, despite, as I say, having one of the best primary care systems in the world. So I think that's a really striking notion. If we have the next slide, please. An important question: what's the variation? Is everyone subject to the same rule of halves? Well, the answer, as we all know, is it depends where you live. And so the next slide, please. So this blue graph shows every practice in England, all 8,000 or so, in rank order. And if we could click through, please. So this shows that your chance of having your hypertension picked up in your practice depends on where you live, and it varies from just under half of you will be detected to about 2/3 will be detected. And the next slide. If we look at treatment of hypertension and click through, this is the how many patients get treated to the generous NICE target of 150/90. Again, my chances of my blood pressure being controlled vary from about 2/3 up to just about everybody. And the next slide. And we see a similar picture with detection of atrial fibrillation, with the management of atrial fibrillation. And one more click. And again, your chance, if you've got high risk AF, of receiving anticoagulation varies from 60% to 95%. And then the final slide in this group. Now this is really striking. So that the bar in the middle tells you what I've already said, that around half of all people with known AF who go on and have a stroke would have been anticoagulated. But look at the range across CCGs in England. So your chances, depending on where you live, vary from almost all of you being anticoagulated down to only a quarter of you being anticoagulated. And the next slide. And this just transfers one of those sets of data. And I should say this is from last year's QOF. It's not been updated yet, but I don't imagine the picture is at all different. But this shows the scope for geographical inequalities across the country when we map these things out. So the next slide, please. How much does it matter? Well, and the next slide. It is really important. And this resource that we developed with NHS England and Public Health England was launched in September by Bruce Keogh and Duncan Selby, shows the size of the prize for cardiovascular disease. And in this case, there's one for every STP in the country. So this is Cambridgeshire and Peterborough. And it's a one-sider. It's a case on one side for taking radical action on detection and management of these high-risk conditions. If you could one click, please. So in the top left, it shows that for hypertension in Cambridgeshire and Peterborough STP, there are 88,000 people with undiagnosed hypertension, and there are 25,000 people with blood pressure that's not treated even to the 150/90 target. Next click. If we look at atrial fibrillation, 7,000 undiagnosed and 2,800 high risk but are not anticoagulated. And then if we move, next click is in the bottom right box. This takes the numbers needed to treat data. So it's a relatively simple calculation and looks at, well, if we forget the people who are undiagnosed and just focus on those who are being treated, if we optimize the treatment in hypertensives, this just to the 150/90 target, this in this STP would prevent 150 heart attacks and 230 strokes over 3 years. And similarly, if we optimized anticoagulation treatment in people with high-risk AF, it would be a similar number of strokes averted. And if we could just move to the next slide, please. And this shows how this scales up for the whole of England. And you'll see in the bottom right-hand box that for optimizing blood pressure, we would prevent 9,700 heart attacks, 14,000 strokes, and optimizing AF anticoagulation, 14,000 strokes. So these numbers are huge and enormous opportunity. And it's important to acknowledge, of course, that this is broad brush stuff. These are indicative figures. And of course, some of it may be an overestimate because there will be people there with hypertension or atrial fibrillation in whom further treatment is not reasonable or may cause harm, or the patient chooses not to have it. But of course, it'll be an underestimate too, because it doesn't take into account all the people with undiagnosed conditions. But this broad brush approach gives us an indication of the size of the prize. And frankly, even if only half of it was true, that's still a very large number of catastrophic events that we could prevent. So the next slide. So why is late diagnosis and under-treatment common? The next slide. And if we could click again. It's important to acknowledge that although it sounds very easy to take the pulse and have informed conversations with patients, actually one of the reasons this doesn't happen is because our consultations are very complex, with patients and clinicians having their own priorities, and there is no capacity for more work. The next slide, please. We're only going to do things, improve outcomes if we do things differently. This is not about getting GPs to work harder or read the guidance one more time. What we need here are system-level changes, which will help to tackle the rule of halves. And the next slide. So embracing that, the 5-year forward view next steps identified this as a key issue, that by doing things differently in AF and blood pressure in particular, we could prevent a lot of strokes and heart attacks. And the next slide. And you'll be familiar with the CVD prevention pathway, which Right Care is now rolling out to every CCG in the country. And this focuses on, in red, the 6 high-risk conditions, including blood pressure and atrial fibrillation and high cholesterol. And the next slide. And if you could just click through 3 times. I'm conscious of time here, so I'm I'm going to move through this a bit more quickly, but this is just to highlight what we mean by doing things differently, and this is what the right care delivery partners will be taking to CCGs and STPs up and down the country. So if we can't get GPs to work harder, how are we going to do it? Well, firstly, by an expanded role for pharmacists around not just measuring, but doing the diagnosis and management of AF and blood pressure, supporting behaviour change and shared decision making, an expanded role for patients on self-monitoring, increasing availability of pulse and blood pressure testing in different settings in the community, use of new technologies, and importantly, generating high-quality local intelligence that will tell us how we're currently performing. And the next slide, please. And so the aim being to develop solutions for quality that also support general practice at the same time. And if you could move through 2 more slides, please. And in fact, onto the next slide. And just before I finish, in a moment we're going to hear examples, some live examples of really excellent examples of doing things differently to have an impact. But I wanted to start just by highlighting a couple of other examples. So in Lambeth and Southwark, if we could click through, please. They use community pharmacists to support general practice in both AF and blood pressure. They saw improved blood pressure control, 1,300 new patients anticoagulated, and look at their estimation of stroke aversion, 45 strokes in 15 months. The next slide, and click through. And in West Hampshire, a similar sort of program, but there's much more GP engagement and education involved there, and estimated 52 strokes averted in 20 months. And the next slide, in Dudley, all the practice-based pharmacists, as well as whatever else they were doing, they focused together on supporting GPs around high blood pressure, and they saw a substantial improvement in blood pressure control and in new cases diagnosed. And the next slide, and one more click. And Bradford Healthy Hearts, many of you will have heard of, and we could discuss it in questions later if you wish, but a really at-scale approach with 21,000 treatment optimizations and 200 heart attacks and strokes averted in 18 months. This was not an estimate, this was a real improvement compared with their comparator neighbouring CCG, demographically similar, who saw an increase in strokes and heart attacks over the same 18 months period. So finally, the next slide. So it seems to me that these are the key ingredients of success if we're going to have this impact. First of all, that in any locality, federation, CCG, STP, to have real clarity of vision, a relentless focus on the size of the prize, knowing so how many strokes and heart attacks could we prevent by doing better in this region, and that should be our driving vision. That it requires as an essential local clinical and other leadership. It requires good quality local intelligence, and with British Heart Foundation support we're developing a national CVD audit prevention tool which will be available locally, we are hoping. They're doing things differently with new pathways and models, but also local leadership that will coordinate support. We know that there are lots of players who are doing stuff around CVD prevention as well as right care, and it's really important that we bring them all together and focus activity. And then the very final slide, and clicking through. So just to summarise, that we do have the potential to prevent thousands of heart attacks and strokes each year, and potential to do this at scale. More of the same is not going to achieve it, but our challenge is, so how do we mobilise the wider system, healthcare professionals and the public to do things differently? So thank you very much indeed, and I'll hand back now to Simon and to the next speaker.
Thank you very much, Matt. As Matt said, we'll now hand over to Kate and Adrian. And just a reminder, for those of you who've got 2 sets of slides, you need to move on to the second set of slides. So over to you, please, Kate.
Good afternoon, everybody. I hope you can hear me. If you can't, then start shouting or something. Okay, this is Kate Arnold from Solihull. Hello?
Hello, you're fine, Kate. We can hear you.
That's lovely, thanks. Okay, so I'm Kate Arnold and my colleague Adrian Tomlinson is sitting alongside me. Welcome to a rather gloomy Solihull in the West Midlands today. What we want to do in the next 15 minutes is just to outline for you a project which we began about 3 years ago to implement the NICE clinical guideline 180 on atrial fibrillation. So we're going to move on to the next slide, I hope. There we go. Okay, so just to remind everybody that the NICE updated their clinical guideline on AF and published it in the summer of 2014. And this guideline was quite a significant update on the previous one. So there were significant changes in recommendations relating to assessing the stroke and bleeding risks and into managing anticoagulation and blood thinning in general. So the NICE guideline update included using the CHADS-VASc2 stroke risk calculator. It incorporated the HAS-BLED score to assess bleeding risk. For the first time, it incorporated what were the novel oral anticoagulant drugs since becoming the, well, I think they're still called NOACs, but the N now stands for non-VKA oral anticoagulant drugs. Importantly, it removed aspirin as a treatment option for low-risk patients. And possibly even more importantly, there was more emphasis on discussion with patients and on shared decision-making, recognising that actually you can prescribe as much as you like, but actually the patient has to take the medication, and therefore it's really important to reach a shared decision about the treatment that's going to be used. So next slide. In terms of implementing it locally, as it happened during autumn of 2014, we already had a series of cardiovascular disease management peer review sessions set up within Solihull CCG. And the GP who was leading this decided that they would focus on the AF guideline, and with the idea that the participants would cascade their learning back to practice. As part of the discussions that took part within these peer review sessions, it was highlighted that it would be immensely helpful if there was a template which could be added to the clinical system, which would guide the clinician and the patients through the process of making the decision about whether or not to anticoagulate. So at that point, Adrian began work on the template. During the following year, we included within our local improvement scheme, our practice development local improvement scheme, a specific requirement that the practice could demonstrate that it had reviewed all patients with a higher risk CHADS-VASc score who were receiving aspirin or no antithrombotic medication using the NICE patient decision aid. And this was really in recognition of the fact that although we could start addressing the issues in new patients, actually we had a fairly significant backlog of patients who'd previously been assessed and who maybe had elected at that point not to go for antithrombotic medication, or had, in line with the previous clinical guideline, been put on aspirin rather than an anticoagulant. And also as part of the LIS, we required audit data, and we required evidence that they were actually using the NICE patient decision aid. And this was supported by a GP protected learning time event on the management of atrial fibrillation, at which point we launched the template more widely across the CCG. So moving on to the next slide, and over to Adrian now.
So we're looking at a clinical template then, which is a page within the patient's notes, which offers links to supporting information. And from a template, the clinician can access the NICE patient decision aid and other clinical tools. And when they're using the template, they'll click on various boxes, and that will record the actions that have been completed in that consultation, so that other clinicians can review those actions at a later date. The patient decision aid, or what we refer to as the smiley faces, is this type of picture where, in this case, it's for a CHADS-VASc score of 2, so the stroke risk is relatively low, but this gives you 17 smiley faces that are in yellow, and that's an attempt to illustrate to the patient that that's the level of risk that they might be avoiding if they start an anticoagulant in an attempt to avoid a stroke. So the aims of the AF template are to support the prescribers in engaging the patient in the decision making. We try to make it convenient for clinicians by embedding the template within their clinical system and bringing into the template all of the clinical guidance that they might need within their consultation. And the template is set out in 3 steps. There are 3 separate pages. The first step is a discussion of the risk of stroke. So this includes links to a patient leaflet, links to the patient decision aid that we've just looked at, depending on their CHADS-VASC score. And so there we'd hope that the clinician can discuss with the patient what the stroke risk might be. They might be able to take away the patient leaflet, have a think about what they've heard, and then come back for another appointment. The next step would be then to review the options that the patient would have. And here obviously there's consideration of the patient might not want to start an anticoagulant at all, in which case the clinician can record that. But if they do want to consider an anticoagulant, then the guidelines, the clinical guidelines for the patients are given. We have links to those depending on which drug is likely to be most effective or most suitable for that patient. And then on the third step, if initiation does actually apply, then we have an initiation page for the anticoagulant. So we have a calculator for renal function. We have notes on what to do if the renal function is compromised. And we have checklists for each of the individual anticoagulants so that the clinician and the patient can review together the fact that they've covered all of the discussion points and the options within this decision-making process. And in terms of improvements that we could make to the AF template, it seems that there's been a decline in use since we started the project in a couple of years ago, and the idea would be to have some form of revision or education event, in which we can remind clinicians of how to use the template, the fact that it's there. Also, edoxaban's come onto the market since the template was first set up, so we would need to add a couple of other items to the template so that the clinician can access supportive guidelines for that newer drug. And also we'd want to add patient decision aids for the risk of bleeding. So for an individual HAS-BLED score, we'd add those so that the patient can then get a fuller picture of the risks and benefits that they might have in terms of their treatment. So I'll hand you back to Kate now.
Thanks, Adrian. So just moving on to the next slide. Because we've been doing this for a couple of years now, we have actually managed to get some outcome data. This is our ischemic strokes by quarter for the period since just before the NICE guidance was published, and are marked at the bottom when the NICE guidance was published and when we began the AF project. I have to say that is not particularly encouraging. So in best tradition, we set off to do a little bit of looking at the data to see if there was another way we could cut it. And what we did was, because we've had a massive increase, or fairly significant increase in population in Solihull over the past 3 years, we began to look at it by patient over the age of 65 on the basis that largely it is our older population who are most likely to suffer from ischemic strokes. And as you can see, once we add once we look at it in this way, we can begin to see that the rate of strokes is beginning to decline somewhat. That trend line would suggest that we had somewhat either 12 or 13 fewer strokes in Q2 of this year than we had in Q1 of 2014-2015. The NICE costing template estimates that the cost of a stroke in year one is around £12,000. So our estimated savings over for that quarter would be around £153,000. This slide actually looks at our prescribing, so it looks at the other side of the equation, as it were. As you can see, we've marked again where the NICE guidance was published and where the AF project began. And I think you will agree that during the period, the 12-month period of the AF project, there was a very definite increase in the number of anticoagulant prescription items. Subsequent to that, it's settled down a little bit, but I would like to suggest that it's still a slightly higher gradient than it was before we began the project. The other side of that is when you start to look at the expenditure on anticoagulation, you can see how much that has increased over the period of time. Again, the somewhat sharper corresponds with the period of time when we were specifically running the project. And again, you will see that that was really quite steep, but in many ways it has continued since. So we now actually have the Q2 data, and we're expecting that that will be somewhere in the region of £450,000 a month, a quarter, that we are now spending on anticoagulation. That compares with the around 150,000 that we think we are saving in costs around strokes. But we have made some assumptions around the calculation. So, for example, we've assumed that all prevented strokes were due to the improvement of anticoagulation. We have assumed that there's no additional savings in strokes beyond what was estimated by NICE, and I think I would suggest that just over £12,000 is a very conservative estimate of the long-term costs of a disabling stroke. And we have made an assumption that all the expenditure on anticoagulation, but it's particularly driven by the NOACs, was for atrial fibrillation, whereas in fact there will also be expenditure for treatment and management of DVT and pulmonary embolism. So that's the summary of our project. I understand that we're going to save questions for the end, but thank you very much for listening, and I look forward to hearing your questions later. I'm going to hand the presentation back to you, Simon.
Thank you very much, Kate and Adrian. So we now have our final presentation from Dr. Neil Macy of Stowe Health in the wonderful county of Suffolk on blood pressure self-management in the waiting room. So over to you, Neil.
Hello everyone, can you hear me?
Yes, we can.
My name is Neil Macy. I'm a full-time in Suffolk, where we look after 19,250 patients. I'm also a board member of Suffolk Primary Care, which is a new single partnership in Suffolk of 11 practices who are looking after about 100,000 patients. So I'm going to tell you about something we've been doing at our practice since 2005. Sorry, I'm just hesitating because I can't see my slides or where I am on the slides.
Apologies, Neil. I just need to reload them this end. So we should be. What's up on my screen now is a picture of your patients outside Stowe Health.
That's great. So essentially what we've done is we've taken 19,250 of these, which are our wonderful patients queuing outside for the flu clinic last a couple of Saturdays ago. If you can move on. We've put one of these automated blood pressure machines in the waiting room, which has got to be the best 1,500 quid we've ever spent. And if you can move on, Simon. We're using these, which is a member of our reception team armed with a very simple decision support algorithm that they use to advise patients about the next steps required regarding their blood pressure readings. So the blood pressure machine is available throughout our opening hours, anyone who requires a blood pressure check is directed to check their own on the machine. Its use is not compulsory. If anyone can't or won't use the machine, we simply book a check with a clinician, but very few do. So pill checks, HRT checks, NHS health checks, they all begin with a check in the waiting room. So how does the decision support algorithm work? If you can move on. Essentially, it has two arms. The first one is to identify potential new hypertension diagnoses. If you can move on. So the blood pressure machine produces a slip of paper with the patient's blood pressure reading, and they hand that reading to the receptionist. Now, if the first reading, either the systolic is above 140 and or the diastolic is over 90, the receptionist simply asks the patient to sit quietly for 5 minutes and check the reading 5 minutes later. And you can move on. If the second reading is likewise, the receptionist then advises the patient to borrow one of our home blood pressure monitors and go home and take a set of monitoring at home. And then we decide to follow up and establish the diagnosis and the need for additional tests on the light of those home blood pressure readings. So we get to that stage without any input from a clinician at all. The other arm of the algorithm is one that helps us to establish whether blood pressure control is adequate in patients with known conditions such as hypertension, chronic kidney disease, diabetes, etc. So what happens, as I said, the patient hands the reading to the receptionist. The receptionist identifies the target blood pressure for the patient based on their disease profile by checking the patient's demographics box on System 1, which is the clinical system we use. We use the QOF blood pressure target, so the lowest is 140/80 for diabetes, then 140/85 for CKD, and then 150/90 for hypertension, CHD, stroke, peripheral arterial disease. But you can set the targets wherever you wish, you just adjust the algorithm. So they check again whether both the systolic and diastolic readings are below target. If you can move down, again, if it's too high, they check it again 5 minutes later. And again, sorry, Simon. And if the second reading again is too high, then they're offered the home monitor again, or if they prefer, we just arrange an assessment with the clinician. Can you just go down? One. If the reading's really very high, then we direct the patient to the duty doctor for immediate review, and that gets sorted out then. If the patient's blood pressure is below the target, the receptionist reassures the patient, and then we ensure that that reading is recorded in the medical record. So we're using this as part of our long-term conditions management program. Our recall letter asks patients to check their blood pressure when they attend for a data gathering appointment with our healthcare assistant. If the blood pressure is too high, the healthcare assistant repeats the reading when the patient's in the room with them, and all the readings are recorded in the medical record. Our patients then come back for their annual review appointment with the nurse about 2 weeks later. If that reading is still too high, the nurse checks it once again. And if all the readings, so we'd have probably at least 3 readings by that stage, if they're all above the patient's target, we really encourage our clinicians to intensify treatment to avoid undertreatment. But we hope that we minimise the risk of overtreatment by not basing treatment decisions on just a single reading. So what are our findings? If you can move on, please, Simon. So as I said, we've been running this for 12 years now, so it's become pretty well embedded, and we've stopped really measuring what it's doing. We audited it back in about 5 years ago when our list was a lot smaller to try and see who was using it and why. And about 17% of people were just people that saw it in the corner of the room and fancied checking their blood pressure, so they weren't the previously diagnosed. 60% were treated to target and so didn't require further clinical input at that time, and only 23% required further clinician input. So at that stage, we thought it looked like it was saving about 15 hours of clinician time a month based on 10-minute appointments. And that is important, and we were really chuffed about that. But actually the real gift that this has given us is real confidence in clinical decision making about changing treatment. So we're not basing it on a single reading, wondering whether we're overdoing things. If you can move on, please, Simon. So patients find this acceptable. Initially, we started it in 2005 when the QOF first started, and a lot of the grumbles we had were actually people that weren't attending for their regular blood pressure treatment checks previously, and they were wondering why suddenly they were getting invited to use this machine. There were also some grumbles about having to take their coats off in the waiting room, but that was fairly short-lived, and now it's, you know, part of the culture of the practice. People hold the piece of paper with their blood pressure reading on, and they know their numbers, and I think they feel more involved with their care. It's very popular with staff. I know that with the 5-year forward view, the move to have receptionists acting as care navigators is popular, but we were using them in this enhanced role 10 years ago, and they love it. You know, they like not being just the dragon that's turning people away for appointments, actually helping people with care. So I'd urge any primary care people out there to, you know, make the most of your receptionist. You can't massage the figures because it's on a bit of paper. You can come down again, please, Simon. As I said earlier, it does save some appointments, but we didn't feel that was the big thing. It was reducing visits and waiting for patients, so working age patients could come in and use the machine on a Saturday morning or after working hours when we were still open without the need to have a clinician's appointment. And you can go down again, please, Simon. And we found that it increased the number of patients receiving their regular blood pressure checks and also helped to increase the number of patients that we had treated to target. So the next slide. So that shows the percentage of her patients with hypertension who had had a blood pressure check in the preceding 9 months. So 2005 was the introduction of the QOF, and we started this on the 6th of June 2005. And pretty quickly, by making the machine available in the waiting room and encourage people to use it, we had a fairly quick and sustained increase in the number of patients having the blood pressure checks that they required. And that graph in blue shows our line compared to local and national averages for the percentage of people receiving checks. If you can move on again. And this shows the level of, or the percentage of hypertensive patients whose last recorded blood pressure was 150/90 or less. Again, as Matt said, that's a generous, nice target, and you set the target where you like. But from the introduction of this system, we've seen a steady and progressive improvement in the percentage of patients controlled to that level. And I think we're currently sitting at about 89–90% of patients controlled to 150/90. The dip you can see in 2014 is the year when the QOF was separated for hypertension by age to a lower target for patients under 80 and a higher target. So it was separated for under 80s to 140/90, and we achieved the 80% target for that without any additional work by using this system. I know that wasn't the case across the country because it caused a lot of GPs and practices to pull their hair out. So we're pleased that by involving the wider team, involving patients, reducing the number of clinical contacts, we're improving the level of patients controlled to this level. You can move on, please, Simon. So in terms of next steps, we've also started to screen for atrial fibrillation in the waiting room using this device called a rhythm pad from Cardiosity. Some of the challenge with electronic blood pressure monitoring is the concern whether it's reliable in the context of atrial fibrillation. So we've been trialling this machine alongside the blood pressure machine to screen people for AF at the same time. You could move to the next slide, please, Simon. Hello, Simon?
Yeah. On next step slide, or did you want the one after? Sorry.
All right, all right.
Yeah. And, slide 77. Hello.
I've still got the picture of the AF machine on my screen. So.
All right. The others have got the next steps slide up.
All right. So the next steps regarding what we're planning to do is we want to automate the algorithm. I haven't included the decision support algorithm because it's a complex looking flowchart, but it's binary. It's very simple. It either the readings are above or below the target. So we want to computerize that and probably incorporate it into an app and then incorporate it into the blood pressure machine itself. So it's actually telling people what to do. It would be nice at the same time to integrate the AF screening. And we'd like to get to the stage where we can import the blood pressure readings and the advice given direct into the clinical record. Ultimately, what this has demonstrated to us is the machine with the algorithm doesn't need to sit in a GP surgery. If you choose your blood pressure target, this can be happening in supermarkets, it can be happening in garden centres, it can be wherever you have people passing through that it might catch their eye, as long as the recommendation to seek intensification of treatment or further monitoring is made clear to the patient. So yeah, that's me done. So I look forward to your questions.
Thank you very much, Neil, and thank you also to Matt, Kate and Adrian. There were some great presentations, and if we could, I know we can't applaud, but if we could sort of virtually give our speakers a round of applause, and then we'll move on to the question and answer session. Please note there's going to be a slight delay whilst we stop the recording and enable the instant messaging function on Skype. So once we've done that, if people on Skype would like to post their questions on the instant messaging board, I will relay those back to speakers. So if you could say who it is you're asking your question to when you do that. And then after we've had some questions via Skype, we'll open the phone lines for people to ask questions. And in order to do that, you need to press *6 on your keypad to unmute yourself. So we're just waiting to see if we've got any questions coming through, and the recording